everyone, Assalamu alaikum. This is Dr. Tazeen from Study Medic and Study FCPS, and we are here with a very beautiful YouTube series for all FCPS aspirants who are going to take their Feb 2025 exams. So here in this series, we shall be covering all important high yield topics, which can be potential exam tested areas in your exam. And the basic idea is to grab the concepts and strengthen your knowledge so that you can perform well in your exam. In today's session, we shall be discussing about small for gestational age, that what are the new recommendations which we have to follow, and how the exam tested questions can be asked in the exam, and how to go about for these questions. So we shall move with this, and here I am covering with you basically small for gestational age. There is a difference when we say small for gestational age and intrauterine growth retardation. Small for gestational age babies can be normally growing babies as well, as it can all depend upon the other features as well. Okay, so small for gestational age newborns are those who are smaller in size than normal for the gestational age, most commonly defined as the weight below 10th percentile for the gestational age. Intrauterine growth retardation is basically that the estimated weight is less than 2 standard deviation from the mean weight. Abdominal circumference is less than 10% for gestational age. They are not normally grown for their potential. Okay, and when we talk about small for gestational age, they can be normally grown babies, but from the standard weight, their weight can be less. So we are actually saying that this can be small for gestational age. But growth retardation is that there can be background, some pathology which can be available. Most common causes can be in the late growth retardation. These can be placental problems can be there. Okay, and it also results in increased risk of complications as well. Okay, so this is the thing which should always be kept in mind. So basically, definition of fetal growth retardation in a previous pregnancy as a risk factor is defined as that when the birth weight is below 3rd centile in the previous pregnancy, early onset preeclampsia or fetal growth retardation necessitating birth before 34 weeks in a previous pregnancy, or birth weight below 10th centile with evidence of placental dysfunction. So what actually we are talking about is that if in the previous pregnancy the risk factors were there, like birth weight was below 3rd centile, which is actually considered as severe retardation, okay, growth retardation. If the previous pregnancy was complicated by preeclampsia, and that preeclampsia resulted in preterm birth before 34 weeks, that is also a risk factor that we say that FGR was there in the previous pregnancy. Or if the birth weight below 10th centile and the evidence of placental dysfunction is also there. When we say that in the current pregnancy, basically, if the estimated fetal weight or abdominal circumference is below 3rd centile, estimated fetal weight or abdominal circumference is below 10th centile with evidence of placental dysfunction. So what we say that about the evidence of placental dysfunction, that this can be abnormal uterine artery Doppler, or this can be abnormal umbilical artery Doppler, where it can be absent or reverse and diastolic flow, or the peak pulsatility index can be above 95th centile. So these things should be kept in mind, that if it is less than 3rd, then whether the other evidence of placental insufficiency is there or it is not there, you will say that this pregnancy is affected by growth retardation. But if the estimated fetal weight or abdominal circumference is less than 10th centile, and also there is evidence of placental dysfunction in the form of abnormality of Dopplers, whether the uterine artery Doppler or the umbilical artery Doppler, this should be kept in mind, that this is known as fetal growth retardation. So fetal growth retardation can be early when we say that this is before 32 weeks of gestation, or it can present late when we say that it can be after 32 weeks of gestation. Before 32 weeks of gestation, if the abdominal circumference or estimated fetal weight is below third centile, or estimated fetal weight or abdominal circumference is less than 10th centile, with at least one of the following, which you have to keep in mind, that the pulse uterine artery pulsatility index is above the 95th centile, and umbilical artery pulsatility index is above the 95th centile, or cerebroplacental ratio below the 5th centile, or we can say that umbilical artery pulsatility index is above the 95th centile. In that situation, we can say that this is growth retardation. In the late fetal growth retardation, which is presenting at 32 weeks or after 32 weeks. So early, the word is used less than 32. 32 or more than 32 is late growth retardation. Here, basically, we say that the abdominal circumference or estimated fetal weight below third centile, or if the abdominal circumference or estimated fetal weight is below 10th centile, combined with at least one of the following factors. So what would be those factors? Uterine artery pulsatility index above the 95th centile, umbilical artery pulsatility index above the 95th centile, cerebroplacental ratio below the 5th centile, or umbilical artery pulsatility index above the 95th centile, abdominal circumference or estimated fetal weight crossing centiles greater than 2/4 on the growth centiles. Okay, so that it is crossing the centiles, then we can say that this pregnancy has late growth retardation, and it needs further evaluation, and it may need intervention as well. So what to do with the antenatal care of these pregnancies where there is suspicion of growth retardation or where there is growth retardation? So how to go about? Basically, the risk assessment is done, and in this risk assessment, we have a look that whether these are low risk pregnancies, moderate risk pregnancies, or high risk pregnancies. And then according to that, their care is tailored according to needs and according to the risk factors present in the pregnancy. For the low risk pregnancies, initial assessment would be maternal history and risk factor evaluation to see that there are any potential risk factors for growth retardation at the antenatal visits. Baseline ultrasound would be carried out, okay, at 11 to 14 weeks of gestation to confirm the gestational age and to establish the baseline measurements. So this 11 to 14 weeks gestational scan is very, very important. That will guide you and that will help you to have a look that this is giving you the confirmation of gestational age as well, so that you can correlate it in the later period. And it is also giving you the baseline measurements, so you can compare when you are keeping the follow-up. Always remember that to diagnose FGR, we always need serial measurements or serial scans to find out that whether this is affected by growth retardation or not. Okay, so then routine antenatal visits would be regular checkups for the patient, and every 4 weeks until 28 weeks, and then it would be every 2 weeks until 36 weeks, and then weekly till delivery. Fundal height measurement would start from 24 weeks onwards to monitor the growth. And here there comes another important point, that an increase of less than 2 centimeters between visits can indicate for further investigation. So what are the visits in which you are actually correlating? That every 4 weekly 28 weeks, every 2 weekly until 36 weeks, and then weekly till delivery. And you are measuring the symphysiofundal height, and there should be an increase of 2 centimeters or more. Okay, if it is less than 2 centimeters, then you should be aware that there may be need of further investigations, that this can end up in poor fetal outcome as well. Ultrasound monitoring and anomaly scan is carried out at 18 to 20 weeks to check for fetal anomalies and to confirm the placental position. This mid-pregnancy scan is very, very important to understand that if any structural abnormalities are present, as in 2 to 3% of pregnancies, structural abnormalities can be there, and placental localization. Why it is important for placental localization? If somehow you are having low-lying placenta, so you can keep a follow-up at 32 weeks and followed by 36 weeks if still it is low-lying placenta. So that is the importance of placental localization as well, in addition to growth of the baby. Growth scans are carried out if fundal height measurements are within the normal range, then there is then routine growth scans are not needed. You know that your the patient's gestational age is corresponding to her symphysiofundal height, so there is no need of growth scans. However, if there are concerns that there is disparity between the fundal height and there is disparity between the gestational age, then it becomes necessary to do the growth scans, to perform serial scans, to see that whether there are any growth retardation features present, or it can be mistaken dates as well, or there can be certain other risk factor as well. But it is very important to rule out this by doing the serial growth scans. Maternal health and well-being is very, very important by advising mother the healthy lifestyle, balanced diet, physical activity she can do, not vigorous activity, but a slight activity can be carried out, and all other features which can add to growth retardation. For example, smoking, alcohol, you should advise and you should support the patient that they can stop that. So it can lead to improvement of general lifestyle, as well as it can help the baby to grow well. So that is important. You should always advise the patient to keep an eye on the fetal movements. This is very important. And what is the gestational period when she should take care of the fetal movements? From 28 weeks onwards. And as in most of the patients, if this is their first pregnancy, it should always be guided that how they have to count the fetal movements and how to seek medical advice if the fetal movements are not appropriate. Blood pressure monitoring should be carried out. Diabetes screening should be carried out at 24 to 28 weeks of gestation. And if this among these any risk factor is there, it should be corrected. Also, the red cell antibody screening as well as anemia correction also comes when we are monitoring the baby. Mothers, plan of delivery should not be beyond 41 weeks of gestation unless there are medical indications for early delivery. So you can go till 41 weeks easily if there are no feto-maternal concerns. And the mode of delivery, it all depends upon the fetal presentation, maternal risk factors, and mother's preferences. So you will assess and discuss the most appropriate mode of delivery based upon the maternal and fetal conditions, with a preference for vaginal delivery if it is possible. And above all, the woman's preferences are also very, very important, that what are the mother's preferences for delivery in addition to presence or absence of risk factors. Postnatal follow-up and neonatal assessment would be carried out through neonatal examination immediately after birth to assess for any complications. Growth monitoring should be scheduled and follow-up should be done in infants' growth, for the infants' growth and development, ensuring that if there are any issues, they are addressed promptly. And patients' education and support is very, very important. They should receive emotional and psychological support, especially in the cases where there are concerns with the pregnancy, where there are concerns with the fetal growth. So all these features, they should be addressed. Okay, so if a woman, she is coming to us and she is a low risk for the fetal growth retardation, we will do the initial assessment by 11 to 14 weeks. As we told that we will be doing these measurements, they would provide us the accurate gestational age as well as the baseline measurements. Then risk assessment and surveillance would be carried out by evaluating maternal history and risk factors, and then regular checkups would be planned. And symphysiofundal height measurement starts after 24 weeks, and we will measure at each antenatal visit, not more than frequently every 2 weeks. Okay, and what actually we discussed, that if it is less than 2 centimeter, then there are concerns that we should seek intervention and we should investigate further that why the symphysiofundal height is that the growth is less than 2 centimeter on visits. Okay, routine scan mid trimesters, mid pregnancy scan would be carried out 18 to 21 weeks of gestation. This is the detailed scan, anomaly scan for the structural anomalies as well as for the placental localization. Follow-up would be based on symphysiofundal height, clinical findings, additional scan if symphysiofundal height is abnormal or any other concerns are there. Okay, and maternal health monitoring should be carried out for the blood pressure, for the diabetes, for the anemia. So routine blood testing would be carried out. Continuous risk assessment is done throughout pregnancy, and the care plan is adjusted accordingly if the risk factors develop later on as well. And delivery planning would depend upon the routine assessment and fetal well-being. Prepare for the delivery around due date unless complications arise. So a low risk pregnancy, no risk factors are there, so you can take the pregnancy as long as possible near term. If complication arises, then you have to evaluate further and then you can do the intervention, but you have to keep other factors in mind as well. Now there comes the care plan for the fetal growth retardation in those patients who are at moderate risk of fetal growth retardation. So risk assessment and initial evaluation should be carried out through maternal history and baseline scan. Serial growth ultrasound examination can be carried out every 2 to 4 weekly. Doppler studies can be conducted. We can conduct Doppler velocimetry of umbilical artery, and we can consider additional Doppler studies if abnormalities are detected. Nutritional counseling provide dietary advice and nutritional supplements if necessary. Lifestyle modification is important. Fetal monitoring advice should be given to the patient. Complications, if any complication arises like hypertension risk is there, so we can start low dose aspirin depending upon the indications of the aspirin, whether major factors are there. If any major one factor is there, we have to start, and if more two or more moderate risk factors are there, then we can start low dose aspirin. Delivery would be planned at 37 to 39 weeks, and the baby care should be by the expert neonatologist, and the baby should be monitored for any complications as well. So for the moderate risk factor FGR, what we are going to do is that the initial assessment as always would be 11 to 14 weeks of gestation. Detailed risk assessment, birth weight, gestation, we will modify the assessment plan accordingly. Uterine artery Doppler would be carried out at 18 to 24 weeks of gestation. If the uterine artery Doppler is normal, we will start the serial scans at 32 weeks of gestation. Every 4 weekly serial scans would be carried out. And if there are any problems with the uterine artery Doppler, we will do the serial scans at 24 to 28 weeks of gestation, and we will be doing the serial scans every 4 weekly. So here basically that is important. The patient is having moderate risk factors. Okay, so you are starting the assessment at 18 to 24 weeks of pregnancy. Then if that is normal, you will start the serial scans at 32 weeks. And if it is abnormal, you will start the serial scans from 24 to 28 weeks. And these serial scans would be carried out every 4 weekly. So this is the potential exam tested area, that when to do the uterine artery Doppler. If it is abnormal, what would be the next step? If it is normal, what would be the next step? And what you are going to do in the next step, that how you are doing the serial monitoring, that is also very, very important. Additional monitoring is always important for the fetal biometry and Doppler fetal well-being assessment. Okay, maternal health monitoring, blood pressure, proteinuria, blood sugar levels, antibody testing, hemoglobin testing to rule out anemia, correction of anemia. All these are basically the routine antenatal care which you are doing. Okay, continuous risk assessment would be carried out throughout pregnancy at the antenatal care, and birth planning and timing of delivery would be based on the risk factors. Early delivery would be indicated only if that is severe IUGR. Okay, if that is severe fetal growth retardation, then early delivery can be planned. Then there comes the antenatal care pathway for high risk pregnancies. Okay, for the high risk pregnancies, basically how to go about, again the same initial assessment at 11 to 14 weeks of pregnancy. Okay, then you will do the initial assessment of birth weight, gestation, and you will do the assessment plan according to the needs of the patient. That would be individualized plan. You can modify it. Uterine artery Doppler at 18 to 24 weeks of pregnancy. Okay, so if it is normal, you will, as this is a high risk patient, in the moderate risk, you were doing the normal Doppler serial scans at 32 weeks. Here you are starting at 28 weeks, as this is a high risk patient for the monitoring. And if this is Doppler is abnormal, then you will do the serial scans from 24 weeks. Okay, so here there is a difference which you should keep in mind, and this is exam tested area, potential exam tested area, that it can be there. Aspirin administration 150 milligrams daily from 12 to 36 weeks. Serial scans every 2 to 4 weeks. Additional monitoring and fetal biometry and Doppler fetal well-being assessment. Maternal health monitoring, blood pressure, GDM, anemia correction, all these comes. If there any complication arises, you have to correct that. Continuous risk assessment throughout pregnancy and delivery planning and time. It all depends upon the presence of risk factors, and you will plan delivery early if that is severe IUGR. Now there comes the delivery plan, that how to go for delivery plan. Okay, in the late IUGR, if it can be gestational age 32 to 36 plus 6 weeks, and you will be doing the estimated fetal weight fortnightly and umbilical artery Doppler weekly. Okay, so during the gestational age 24 to 25 plus 6, and then it depends upon the other gestational age period, that how to go about. What you will do, you will see that if it is absent end diastolic flow or reverse flow in the umbilical artery, you will do the monitoring every 2 to 3 weekly. Okay, you will do the monitoring every 2 to 3 days with continuous CTG or ductus venosus Doppler, unless delivery is indicated. And what actually is the indication of delivery? That is the abnormality in the ductus venosus Doppler. To time delivery, we are actually using ductus venosus Doppler. So personalized management would be there for the patient. Generally, we consider at 32 weeks, but it can be considered at 30 weeks if there is reverse and diastolic flow. Back pulling is very dangerous, so always remember that then you have to plan delivery. If it is 26 to 28 plus 6 weeks of gestation, you will do the assessment in the regular way, and you will deliver if there are abnormalities in the ductus venosus Doppler A wave, or STV is less than 2.6. Okay, so then 29 to 31 weeks of gestation, you will do the monitoring. If it is absent or reverse flow, monitoring would be carried out with CTG, or ductus venosus Doppler would be carried out. Okay, and then if there are abnormalities in the ductus venosus Doppler, delivery can be planned. Generally, we are considering delivery at 32 weeks. It can be considered before 32 weeks if there are concerns are there. Okay, so then there comes late FGR. Okay, so what actually we come, generally birth is should be initiated in those patients who are low risk, and when there are not much risk factors present, we can deliver them at term or near term. Okay, 37 weeks, 37 plus 6 weeks, we can go for delivery. So in the gestational age period 24 to 33 plus 6 weeks, if absent end diastolic flow is there or reverse end diastolic flow is there in the umbilical artery. Monitor every 2 to 3 days with CTG and ductus venosus Doppler. If ductus venosus becomes abnormal, deliver. If it stays normal, then to be delivered at 32 weeks and absolute by 34 weeks. Okay, and if this is a period of gestational age 34 to 36, if umbilical artery pulsatility index is more than 95th centile, you will monitor minimum twice weekly, and you will deliver if absent diastolic flow is there, and delivery time would be 36 to 36 plus 6 weeks. Okay, so if the gestational age time period is 37 to 38 plus 6 weeks, in those patients in which you are doing the monitoring for due to concerns for the FGR, you will deliver if spontaneous repeated unprovoked decelerations are there, if abnormalities in the ductus venosus Doppler are there, absent or reverse flow in the umbilical artery, or there are signs of cerebral redistribution or maternal indication is there. Okay, you will deliver by 37 to plus 6 weeks if abdominal circumference estimated fetal weight is less than third centile. It means that it is severe growth retardation. More than 39 weeks, any patient who is coming with concerns of small for gestational age, they should be delivered. Delivery should be planned as they have achieved appropriate gestational age, so they should be delivered. Okay, now there comes that when we were talking about the low risk factors, low risk are the patients when no risk is there. Okay, and then we are planning their doing their anomaly scan, and then serial measurements of the symphysiofundal height. We will reassess at 28 weeks and after any antenatal assessment. Then moderate risk factors are there, which can be obstetric history, previous SGA, previous stillbirth. Current risk factors can be there, like in the mother, if they are smoker, drug misuse, age is more than 40 years, BMI less than 18, or it can be gastric bypass surgery, previous preterm birth is there, second trimester losses are there. So all these are the moderate risk factors which we assessed. And for the moderate risk factor, initial scan was at 11 to 14 weeks. We were doing the assessment, then anomaly scan, mid pregnancy scan, and then we are doing the serial assessment from 32 weeks every 4 weekly. Okay, and then there comes the high risk factors, and in the high risk factors, any pregnancy which is complicated by the medical disorders, okay, like chronic kidney disease, hypertension, autoimmune disease, SLE, APLS, or complex cardiac disease is there. Obstetric history is significant, like previous baby was affected by growth retardation, hypertensive disease in the previous pregnancy is there, previous small for gestational age birth was there, or in the current pregnancy associated plasma protein is less than 5th centile, inhibin A is more than 2 milliosmol per millimeter. Okay, alpha fetoprotein is more than 2, echogenic bowel is there. Okay, significant bleeding is there, patient is coming with antepartum hemorrhage, estimated fetal weight is less than 10th centile, or single umbilical artery is there. Okay, this is putting the risk patient at the high risk, and then you will do the uterine artery Doppler. Okay, followed by that you will see that if the uterine artery Doppler and estimated fetal weight is more than 10th centile from 32 weeks. If it is less than 10th centile, you will monitor from 26 to 28 weeks. It means that uterine artery Doppler is normal, but it is less than 10th centile. Okay, if uterine artery Doppler is abnormal but estimated fetal weight is more than 10th centile, you will do the serial assessment from 28 weeks, every 2 to 4 weekly assessment. And if the uterine artery Doppler is abnormal, also abdominal circumference and estimated fetal weight is less than 10th centile, you will discuss that with fetal medicine unit, as it is umbilical artery Doppler, that uterine artery Doppler, that is also abnormal, and also the estimated fetal weight and abdominal circumference is also less than 10th centile. Okay, so for the patient's reassessment is done at 28 weeks, and then you will diagnose that how to go about for the serial scans in those patients when you are doing the risk assessment. Okay, so that is also very, very important. So women can be there with unstable, who are unsuitable for monitoring of growth, like symphysiofundal height measurements are problematic. That can be high BMI, that can be fibroid with pregnancy, that can be congenital uterine anomalies. So here you cannot assess appropriately the symphysiofundal height. In that case, you are doing the anomaly scan. Okay, if the estimated fetal weight is more than 10th centile, you will do the serial monitoring from 28 weeks in women with congenital uterine anomalies. Okay, and 32 weeks in women who are unsuitable for symphysiofundal height every 4 weekly until delivery. So there is a difference. With the congenital abnormalities, the risk is more, so they are monitoring from 28 weeks. With the presence of fibroid in pregnancy, okay, or high BMI, then it is being monitored from 32 weeks, which should be kept in mind. Okay, and then there comes the early FGR, and then there comes the that how to go about for monitoring. As we discussed, that we will keep in mind the gestational age. If it is 24 to 25 plus 6, we will see that what is the situation on the Doppler, okay, and the ductus venosus Doppler and CTG, and the care plan would be individualized care. Okay, so if we will deliver by 32 weeks, if reverse and diastolic flow is there in the umbilical artery, we can consider from 30 weeks onwards. Okay, so and in other cases, what actually we can do, 29, if the gestational age is 29 to 31 plus 6 weeks of gestation, we will keep monitoring and we will follow the Doppler, ductus venosus Doppler and CTG. If the ductus venosus Doppler A wave is absent, okay, so then what actually we will do is that we can deliver by 34 weeks. If absent and diastolic flow in the umbilical artery, we can consider from 32 weeks. Okay, same is the situation when it is presenting at 32 to 36 plus 6 weeks of gestation. We will keep on monitoring on the Doppler, okay, and then we will see that what is the situation on the ductus venosus Doppler, and the delivery plan can be 36 to 36 plus 6 if the pulsatility index and is more than 95th centile. Okay, and then there comes the patients who are coming at term 37 to 38 plus 6 or more than 39 weeks. Okay, 37 to 38 plus 6 weeks, if the patient is coming and there are concerns for intrauterine growth retardation, we can deliver if the abdominal circumference or estimated fetal weight is less than third centile. Means that it is the things are getting worsened. Okay, we can deliver by 37 plus 6. When FGR cannot be excluded, discuss the management plan. And if the patient is at 39 weeks, then we have to deliver at 39 weeks if there are any concerns. We will deliver if there are spontaneous repeated decelerations on the CTG, maternal indication is there, abnormality in the ductus venosus Doppler is there, or absent or reverse flow is there on the umbilical artery. So that is something which should be kept in mind. So basically the risk assessment is very, very important. After the risk assessment, you have to have a look at the gestational age, and then the investigations, that what the Doppler says. Okay, depending upon those Doppler findings, you will plan the delivery plan for the patient. Okay, I hope this will help you in your exam preparation. Okay, so if you have not subscribed the YouTube channel of Study Medic, subscribe now for the more upcoming series, and stay tuned and stay aware about the latest guidelines and the recent updates. I wish you all the very best for your exam. Have a great day.